Okay, great. So now this is very important talk, and this is 2022 talk, management of urogynecological problem in pregnancy and the postpartum period. Now, first of all, this is recent, and the other important thing is previously also in exam they have asked question from this talk, which was old talk of 2012. So this is now a new talk of the same topic, which was of 2012. Now in 2022 they have given the new article about the same topic, and this is always the exam favorite, so you should know it really well, remember it really well, because in exam definitely you can get question from this talk. So let's discuss what all can happen in pregnancy and postpartum period. So SUI can happen. Yes, in pregnancy the muscles are weak, everything is becoming weaker, so SUI can happen. Overactive bladder can happen because the uterus is pressing on the bladder. So always overactive bladder in first 3 months and last 3 months is common. Prolapse can happen, yes, because the muscle are weak again. So the treatment could be exercise or pessaries because you don't want to do surgical treatment. Always for a pregnant woman or reproductive age group, all the urinary problem or prolapse, you want to treat them conservatively. You want to avoid surgery till they complete their family life. Keep this fact in mind because in exam if they ask you what treatment modality, never choose surgery as your first choice for reproductive age group women or pregnant women, postpartum women, because things are changing. Pregnancy and postpartum is a different state. Once they come out of it, their symptom might change. They might not need anything. So you can't offer a surgery for a pregnant woman and a postpartum women. Give them 1 year to recover from all the pregnancy and labor related trauma and then decide what treatment they need. So this is what you should remember always. Recurrent UTI can happen in pregnancy. We all know that UTI, female is always prone for UTI, and in pregnancy, further the risk increase. Retention can occur anytime in pregnancy. Again, reason could be many, either due to bladder distension, voiding problems, or sometimes difficult deliveries that can lead to problem of urinary retention. So if we talk about SUI in pregnancy, how much you see that and how you're going to treat that. So muscle weakness leads to SUI. Pregnant women will be having less strength, so there will be higher chance of SUI. So the prevalence will be higher in pregnant women compared with non-pregnant. Now the precipitating factor or the risk factor would be same as for non-pregnant, like high BMI, increase intra-abdominal pressure leads to SUI, smoking, constipation. These are all risk factor contributing to SUI. If we talk about which is the commonest type of incontinence during pregnancy, SUI is the commonest type. We also saw in NICE guidance that the most common type of incontinence anyways is SUI. So even in pregnancy, it is the commonest type with the prevalence ranging from 19 to 75%, which will increase with gestational age. So as the pregnancy increase, the muscle weakness further deteriorate and SUI further become evident. Even they say the women who are having it in third trimester will further become worse in post pregnancy. So postpartum it will become further worse. Mode of delivery can affect whether it will resolve or not because vaginal delivery will be in stress. So vaginal delivery increased the long-term SUI by 8% compared with cesarean section. So that's one thing you should remember, that vaginal delivery is always a risk for prolapse and SUI. They say that up till 73% of the women who has SUI pre-pregnancy will have symptom in pregnancy. And the incidence who had no symptom prior to pregnancy will be much lower, which is 12%. So if they had it pre-pregnancy, obviously 3 in 4 will have it. If they didn't have it pre-pregnancy, only 12.6%. First line treatment, same as non-pregnant women. PFMT will be the first line treatment. And here you will try harder with PFMT because You don't want to operate on a woman who has not completed their family. So PFMT is very, very important, and they say that if you tell them to do PFMT in early pregnancy, even for a continent women, by that you can avoid the SUI in late pregnancy and postpartum. So all the women, all pregnant women, if you educate them to do PFMT in early pregnancy, it would be beneficial for them in later gestation and postpartum period to avoid SUI. How you will treat SUI in pregnancy? Again, first line is PFMT. And NICE do not recommend the use of intravaginal intraurethral device. So you will not prefer the pessaries for incontinence pessary for SUI in cases of pregnant women. Surgical treatment you will never usually consider until her family is complete. If the woman wants to become pregnant, means she told you that her family is complete, she doesn't want any further children, she has undergone the surgery, and after that she changed her mind and she again become pregnant or she wants to deliver. In that situation, you have to inform her that there is a risk of surgery failure, which she has to keep in mind if she delivers vaginally, or even if by cesarean section, there is a risk of failure of uh, surgery because the muscle will become weak with pregnancy. So they say that mode of delivery is not going to affect the recurrence, which you should keep in mind because we feel that vaginal delivery is always a more risk than cesarean section, but they say that mode of delivery will not affect the SUI recurrence following surgery. Postpartum, again, lifestyle modification, you will always advise to all the women with incontinence and then gradually PFMT, and she will wait and watch at least till 1 year. So this is all about SUI in pregnancy. If SUI, the risk is more. If they have pre-pregnancy, the risk is 3 and 4. This is SUI is the most common incontinence in pregnancy. The first line treatment is PFMT. You will not advise pessary, and surgery you will try to avoid till they finish their family. Then comes the overactive bladder in pregnancy. So again, 41% of the pregnant women will experience some frequency. We all know that in first trimester and last trimester, the things are more common. As the uterus expands, the bladder capacity reduced by more than 100 ml in third trimester. That's the reason. Fetal head engagement also irritate the bladder. Urgency will be seen in up till 31% of the women. Regarding the parity with OAB, they say that there is no strong association between parity and urgency and OAB. So we think that parity is related to everything, but parity is mainly related to SUI and prolapse, not overactive bladder. Regarding the treatment guideline, there is no specific treatment guideline for OAB in pregnancy, but the NICE guideline applies. NICE guideline, the treatment of OAB applied to OAB in pregnancy as well. So if we see that primary will be the conservative measurements, like conservative measures like modify the fluid intake, reduce caffeine, pelvic floor muscle exercise, bladder retraining. These are the first modality. Then will come the drugs, so anticholinergic drug. They say that oxybutynin is the most tested drug. For ages and ages it has been used. So though the safety aspect is not fully established, but still you can use it. Even in breastfeeding women, you can see some lactation suppression can happen due to oxybutynin, but if she needs it, she can use it. Intravaginal estrogen, she can use it postnatally because postnatally the estrogen level is low because of breastfeeding and prolactin hormone. So always local estrogen is advisable in breastfeeding women to keep a good health of vagina as well as sexual health as well as urinary health. So that's advisable in postpartum women. If the primary conservative measures and drugs doesn't work well, then the Botox. So again, they say that Botox may be used in pregnancy, but it's not commonly offered because yes, there is some bladder problem, but at the same time, any invasive treatment in pregnancy you don't want to do because baby is also there. You don't want to uh, worsen the problem. You don't want to give her an extra procedure in pregnancy. You always try to avoid. So can be used but not commonly offered. Percutaneous sacral nerve, they say that you shouldn't offer in pregnancy. So you can go up till botulinum if needed, but try to avoid botulinum. So you will do the conservative measures and the anticholinergics if needed. And for postnatal women, you can give intravaginal estrogen. Yes, urodynamics can be done in pregnancy, but with the limitations of pregnancy, everything is altered. So urodynamic, it's not like you can't do, but at the same time, there is not enough evidence. Urodynamics is a test of telling you about bladder stability and things like that. Like urinary tract infection, alter things. The same way pregnancy also alter things. So it's difficult to predict the outcome of urodynamics. But yes, if you're planning botulinum for her, you have to do urodynamics before that. But as I told you, you will they have mentioned that you will not commonly not offered means in exam for exam all practical purposes in exam you will not choose botox is what they're trying to tell you because you don't want to offer it is what they're trying to tell you because of the limitations basically. Okay, so we discussed about SUI in pregnancy, we discussed about OAB in pregnancy, and the third thing is the prolapse. So pregnancy and delivery are always a risk factor for developing prolapse, right? Prevalence is 5 to 10%. They say that prolapse will keep worsening from third stage to 6 weeks postpartum. If you'll see, you will see there will be some worsening. What are the factors which will determine that if she will have prolapse or not? These are the difficult delivery, forceps delivery, prolonged second stage where the head will keep pressing on the levator ani and lead to avulsion of levator ani, damage to levator ani. Large baby, again, there is injury to levator ani, damage. Third, fourth degree tear means it was a difficult delivery. And again, third, fourth degree tear means the pelvic floor has got damaged. What you will do if you find prolapse in pregnancy? Even during uncomplicated delivery, what happens is because of the pressure of the fetal head, there can be damage to levator ani. And puborectalis muscle is the most prone to damage, which will lead to prolapse. So they can always ask you in SBA that which muscle of levator ani get damaged most commonly in while labor or while delivery. So puborectalis is the muscle which get damaged, leading to subsequent prolapse. Even in uncomplicated vaginal delivery, the levator ani can get avulsed. If it get avulsed, there will be increased risk of cystocele prolapse, which is twice as likely to go to stage 2. So they may ask you that, what's the risk? So it's twice risk because of levator avulsion. How you'll manage it in pregnancy postpartum, as I told you, conservative management, altered lifestyle, diet, exercise, PFMT, vaginal pessary. This is how you want to manage. You don't want to do surgery in pregnancy always. That's your first plan. So you will try to manage this conservatively because the prolapse also will change after delivery. And as I told you, after 1 year, the muscle strength will change and prolapse degree might change from second degree it become first degree and the patient doesn't need any surgery. So it's important that you don't operate in pregnancy for prolapse. Manage it at max by pessary. You will not offer even after delivery if a symptom improve or if it persists. You don't want to offer her surgical treatment till her family is complete because any prolapse surgery will get compromised by future pregnancies and deliveries. Then comes the recurrent UTI in pregnancy. We discussed about recurrent UTI TOG already. Now, recurrent UTI in pregnancy, again, the chances of UTI in pregnancy is approximately 8%, which could lead to pyelonephritis in up to 2%. So it's quite significant UTI. UTI in pregnancy is not a good thing because it can lead to further complication like preterm birth, stillbirth, chorioamnionitis, SGA babies. So you always want to treat UTI in pregnancy overzealously to avoid the complication on the baby and pregnancy as well. If we talk about UTI, because of the hormonal changes, because of the progesterone leading to dilatation of the relaxation of the ureter and things like that, you always there is a risk of UTI. And the other most important factor is asymptomatic bacteria. So what is asymptomatic bacteria? Women has no symptom, but when you did culture, you found that there is 10 to the power 5 colony count found in the culture. That is called asymptomatic bacteria, which you should treat. Though the incidence of asymptomatic bacteria in pregnancy is same as non-pregnant, approximately up to 7%. But if you don't treat it in pregnancy, then she will have UTI 1 in 4. 25% women will develop UTI. So in UK, the practice is that in early pregnancy, at least once in the beginning, they do urine culture just to make sure that she's having asymptomatic bacteria or not. And if she has it, they treat it with antibiotic to avoid her having the UTI in future, which the chances are 1 in 4. So if recurrent UTI happens in pregnancy, the diagnosis also will become difficult because you always have to confirm it with urinary culture. If the culture positive uh, comes, then only you can tell that it is UTI. It can be due to E. coli or it can be secondary to many bacteria from the vagina sending infection and things like that. So because of the altered hormone, because of altered anatomy, because of altered physiology in pregnancy, it's difficult to diagnose UTI as well as to document it. You have to every time do the culture. The main risk factor for recurrent UTI are young age, family history, sexual intercourse. They say that if they have more than twice a week sexual intercourse in pregnancy, the risk of UTI is more. High parity, because again, the muscle strength will be less. Lower socioeconomic status because of hygiene. Hydronephrosis, because if you do an ultrasound and you find hydronephrosis, that means your the pelvic calyceal system is dilated. So if it is dilated and lax, again there is stasis and risk of infection. So hydronephrosis and stones. Again, stones can lead to infection. So these are the risk factor of recurrent UTI in pregnancy. So what you will do? Prophylaxis, very, very important. This slide is the most important, I believe, for recurrent UTI in pregnancy. So what NICE says that you can give antibiotic prophylaxis as well as you can give non-antibiotic prophylaxis. So what are the antibiotic prophylaxis recommended is trimethoprim 100 milligram or nitrofurantoin 50 to 100 milligram overnight. So every night she will take one trimethoprim, one nitrofurantoin, or amoxicillin cefalexin, amoxicillin 250 milligram or cefalexin 125 milligram. So this is recommended antibiotic for preventing recurrent UTI for a pregnant woman, because recurrent UTI in pregnancy can lead to many problems related to pregnancy like preterm chorioamnionitis, SGA, pyelonephritis, which could be very sinister. So you want to avoid it. So you will give the antibiotic prophylaxis. At the same time, there's no specific guideline which says that after every urinary tract infection treated, you have to do culture. But usually in pregnancy, you do that to make sure that the infection got cleared. If a woman gets recurrent UTI in pregnancy, you have to do fortnightly testing until 36 weeks of gestation and then weekly until delivery. This is a very important point. They can always ask you in SBA that how you're going to follow her up. So fortnightly until 36 weeks and weekly until delivery after that. What could be the non-antibiotic prophylaxis? So we already know D-mannose from the previous talk, and the other could be methamine. Methamine, though, the methenamine, though in non-pregnant, they say that still enough data is not there and more trial is needed. But in pregnancy, they told that you can use methamine hippurate. It could be useful. So these are the two things you can choose in exam, or these 4 antibiotic you can choose. And this is how you're going to follow her up in remaining pregnancy. Culture. Dipsticks are always done in every visit for a pregnant woman here in UK, and which is what antenatal recommendation, isn't it? That any women coming for the visit, you have to do the dipstick, not only to look for infection, but also for protein, glucose, and things. So here you will do the culture. Now, urinary retention during pregnancy. This is a very commonly asked question in previous recalls. As I told you, urinary retention, how you're going to manage. And also in MRCOG Part 3 exam, this is important, how you will manage them. This is common station. So 20% of the women who have retroverted uterus will, usually it corrects as the pregnancy advances, it corrects. But sometimes the retroverted uterus become fixed, maybe due to adhesion, due to malformation, due to deep cavity, and usually it will present. How long do we have to give antibiotic in a pregnant woman? For pregnant women, if you give for asymptomatic bacteria, you have to give it for 3 days. If you are giving it for UTI proper, you have to give at least for 7 days. So as I was talking about urinary retention, retention usually will get automatically corrected once the uterus enlarge and come out of pelvic cavity. But sometimes it is a fixed retroverted uterus, which will be seen in 1 in 3,000 to 10,000 pregnancy, which will present between 14 to 18 weeks of gestation, where the cervix is pressing on the urethra because the uterus is dipping down in the pelvic cavity. So cervix will come forward and press on the urethra, and that's why. My dear, any UTI in pregnancy you will be treating for 7 days, as any UTI you will treat. And then if it is recurrent UTI, the only thing different will be you will give her prophylaxis to avoid future UTI. But it won't be a prolonged treatment because any episode of UTI will be treated the same way as any UTI. So 7 days treatment should be enough in pregnancy. Am I making sense, Yapa? Okay, great. So we were talking about urinary retention. Retroverted uterus usually correct themselves, but fixed retroverted uterus can present between 14 to 18 weeks of pregnancy. Reason could be all this. Not only in pregnancy, during labor also again, the inefficient bladder emptying will lead to over distension of bladder and then urinary retention and then later on overflow incontinence. So bladder health during labor and delivery is very, very important to maintain. Women should keep voiding to avoid infection, to avoid distension, to avoid retention, which should be taken care of during labor. If there will be retention and distension, it can cause to the muscle damage, hydronephrosis, long-term consequences like voiding problems, detrusor underactivity, increased frequency nocturia. These could be the side effects. Now, the important question asked in exam is about postpartum urinary retention. Postpartum urinary retention is a common condition after childbirth with the prevalence of approximately 14 to 24%. This you should remember. So it's like 1 in 6 to 1 in 4, which you should remember. So 14 to 24% of the women after delivery will have retention, which could be either overt retention, which is like she couldn't pass urine within 6 hours of delivery, then it become overt retention, or it could be covert retention. Covert retention means she could pass urine, but the post void residual volume is equal to more than 150. So they can ask you anything about it. the percentage, what is overt PUR, what is covert PUR, and how you're going to treat it. So how you're going to treat it, this algorithm, this chart is very, very important to understand and memorize. Any women after delivery, you want to encourage them to void. You want to avoid over distension, retention, overflow, incontinence, and future problem due to all this. So this is developed by King's College Hospital, London, how to manage a woman with pregnancy or post-delivery retention, postpartum, how you are going to manage it. So you encourage them to void within 4 hours. If they have epidural, they usually have catheter. If they have cesarean section, they have catheter. Some difficult instrumental delivery, PPH, they have catheter. So you'll tell them to remove the catheter, and after catheter, they should be passing urine within 4 hours. So encourage hydration and encourage passing urine. If they don't pass within 4 hours, you will give them further 2 hours, and total of 6 hours you will give them to pass urine. Once they pass urine, you always measure that. So document the voided volume, how much they have voided. Because if very less voided volume, like less than 150 or less than 200 voided volume, that means it is not adequate. So document the voided volume. If they are not able to void, then you have to do an in and out catheter. And after, you have to measure the in and out catheter will also help you in measuring the how much amount of urine she has passed, means how much residual urine is there. Sometimes if they have not voided enough, in and out catheter will tell you about the residual urine also. So if the residual urine is less than 150, then it's all right. For a postpartum woman, less than 150 is all right. But if the residual urine is between 150 to 250, you will tell them to again do another attempt. So you will give them 6 more hours to void on their own. If it is 250 to 700, which is quite significant, then you will insert a catheter and do TOG after 24 hours. If it is more than 700, then you have to tell them to go home with catheter and come back in 2 weeks' time for again TOG. So remove the catheter and encourage passing within 6 hours. The same rule apply. So this range you should remember, because in exam they'll tell you she's unable to void and you put catheter and you found this much volume of urine, what to do? Or residual urine is this much, what to do? So if residual urine fall in this category, then you have to follow this algorithm. The same will apply here. If she has voided, but good volume is not there, she doesn't feel empty, she still feels sensation of passing, stream was not normal, incontinence was there. So any of these were there, then again you have to measure the residual volume. If residual volume is less than 250, the same like this, then again another attempt. If 250 to 700, insert catheter. More than 700, go home with catheter. For the second void, which you told her to do within 6 hours, again for second void, if it is less than 150, it is good. But if it is 150 to 700, you will insert the catheter. So for second void, again, you will not wait till 250. For second void, the criteria is 150. For first void, it is up till 250, where you encourage them to do second void. In second void, it should be less than 150 residual. Then only you will tell that it is successful TOAC. If it is more than 150 to 700, this range, it will be keep catheter for 24 hours. If it is more than 700, keep catheter for 2 weeks. Am I making sense? Is this chart clear to you all? This is very, very important, very recent information, and I'm sure you will get a question from this chart in your exam. So this you should really learn by heart.